So I'll start by just showing that the spectrum of flat foot is very different. The topic given was symptomatic flat foot, so obviously I've added some of these severe ones as well, but the main essence is on flexible flat foot. Now that flexible flat foot presents at birth and can persist up to adolescence. That's been very well documented. It's not that all flat-footed arch will have pain, but there are certain subset of population in adolescent as well as children where they will manifest with symptoms. Now, of course, clinical assessment, all of us will do a thorough assessment to make sure that we don't miss any syndromic feat, and most of the children will have some forms of hyperlaxity, which is the norm in most small children. So, only thing you have to make sure you don't miss any signs or neurology or anything which is syndromic. Of course, don't only look at the feet, look higher up as well, because knee, hips, spine can all manifest as flat foot. The reason I showed this photo of a chappal is where parents complain how my child's foot is slipping out of the slippers, so he's unable to play as a normal kid. Of course, that's not a symptom though. Again, examination becomes important. One more thing which I would add to Tushar's examination is the pedobarograph. And today what we do is, we look at the foot impression. And there's a lot of information now one can get regarding the source of pain by doing what is called a foot pressure study or a pedobarograph. And we also utilize this in our own setting, and also we do x-rays. So don't think it's merely a flat foot, it's a chubby foot, but there are lots happening in the 26 bones of the feet. Sometimes these are the source of the pain, and somewhere or the other, one can ascertain where the pain is coming from. So you can look at conditions for accessory navicular, calcaneal problems, tarsal coalitions, and this is one of my doctor's daughter who could not sit cross-legged because of the tarsal coalition. So there are certain symptoms in symptomatic flat foot one should be aware of. Of course, we have seen an exponential increase, just like in genu valgum, there has been an exponential increase in flat feet post-COVID. And again, there are various factors for that. And we typically see in a month, about 5 to 6 children coming with a flat foot. There are different types of flat foot which have been classified depending on where the collapse of the arch is, whether it's in the subtalar joint, mid-tarsal, or it's a mixed variety of flat foot. So again, X-rays become extremely important. One should look at the forefoot adduction, the collapse of the arch, and the hindfoot valgus. So there are various angles that has been described, but most important, remember the talus first metatarsal base angle, both in AP and lateral, and the calcaneal pitch angle. Those two are the most important. And that will at least give you an idea where the foot is collapsing and also what is the cause of the symptom. And typically these children with the collapsed arch will complain of pain on the instep, they'll have calf pain and knee pain. Calf pain is a very, very important sign of flat foot, and don't ignore that. So when they complain of calf pain and leg pain. And the calcaneal pitch angle again is important, which tells you the magnitude of the flat foot based on the calcaneal inclination. The newer concept which is coming now is what we call the Syma line, which is basically a line joining two curves. So here you look at the line joining the calcaneum and the talus, which should form a smooth S. If there's a collapse of the foot or there's break of the talotarsal joint, then this line is broken. Of course, we are using this Clark's angle, which is now the gold standard to measure or to at least document flat foot. So even if you don't want to treat them surgically, at least document the severity by doing certain imaging studies. So we look at the Clark's angle, anything less than 30 degrees is considered to be a flat-footed, and this is well published in literature. Also, there are a lot of studies looking at gait studies in these children, why they get pain. So we also have looked at children which have got symptomatic flat feet. So these are 30 children who have symptoms. They are not control group. So we are going to compare them with the control. And we looked at their range of motion. We did a gait analysis. And this is how we look at the gait pattern, and we look at the ground reaction force as these children walk. So these are symptomatic feet. And what we found that these children have got reduced dorsiflexion, they got external foot progression angle, they got reduced subtalar motion, and also they have decreased ankle power. So the ankle power is reduced considerably when they have got lack of push-off. And we've got the gait lab now in mine. We also got the jockey here. So I think she can support us for the treatment of flat foot. Now this is an example of a child who had bilateral flat foot, again symptomatic. Calf pain, mainly calf pain. Foot pain was there only with walking, prolonged walking. She had tried all insoles, she had tried plaster technique, everything didn't work. And that's the time we opted to do what is called a foot stent procedure, where we insert a screw in the sinus tarsi And also with that, we did a tender Achilles lengthening. So we did a calf lengthening as well. And this is what the other people don't do it. If you do a calf lengthening, it may not restore the arch, but a lot of the calf pain goes away. So this was another child which had got that collapse of the midfoot. You can see the Simon line is broken. The calcaneal pitch is less than 10 degrees, and we put the foot insert, the calcaneal insert. This is a very small device we put in the sinus tarsi. It's got done through a small incision. Again, post-op, we put them in a brace for 6 weeks, and then they can resume sports. This child actually went to Dr. Tushar, and he had offered him surgery. This child was given orthotics. They said, no, I've got too much pain, too much calf pain, too much knee pain. He came to me, he said, I've already used whatever has been mentioned before. And he went ahead and we did a surgery for him. We gave him a cast for 2 weeks. He's now wearing this orthotic and he's now pain-free. So he mainly came with calf pain and knee pain. And he had both sides, but we didn't do both together. We've done only one leg at a time. So there are, of course, some data on this procedure. It is not benign, so I would not recommend every child needs it. Maybe 1 out of 10 may need it. There are complications, so if you put the placement of the stent is wrong, potentially it can dislocate, can cause more problems. But there is enough evidence in literature to show that all flat-foot children are not completely asymptomatic. They will have some difficulty in walking, they will have some difficulty in the knee, and they'll have calf pain. And sometimes it can also pain can come proximally into the hip joint. And all of them have reduced dorsiflexion, which perhaps explains the calf tightness and subsequently they're getting knee pain. So this technique of using a PET screw, like a PET screw, is a simple screw again. You put in the sinus tarsi, but you have to document. You have to document what the symptoms are. You document with a gait report. You document with a pedoparagraph. And of course, we've done only 3 cases so far, so I'm not saying I'm an expert. But there's a limited role for this technique in select cases. But you must document them, and subsequently, we'll test them again in the gait lab. There have been previous devices also in the past. There are this device called the Kale device, the Gianni device. Both have failed because they were bioabsorbable screws. They failed because the screw got absorbed. In some cases, the screw got dislodged. So the titanium screws actually works well. This procedure, what is called the calcaneal stop procedure, where they put a screw in the joint, that was not very successful because the talus used to get eroded. So that again has been given up. The results of this procedure, what is called the extraosseous talotarsal stabilization, they have done for children as well as adults. The best results are seen in children because in adults there are several other secondary joint problems. So they found that the outcomes are better in the pediatric population, and that's what the population which we see, adolescent children with foot pain. Of course, I have also done lengthening. I have done lengthening also for a flexible flat foot in a very severe child who had a lot of symptoms. This was described by Win Mosca, and this again restores the arch very well. And this is an old age technique to correct all the deformity components. We've done excision for talar calcaneal navicular coalition. Of course, these are classical symptomatic flat feet which need treatment. So we have excised the coalition in this child, put bone graft. So in conclusion, even Pele had a flat foot. So it's not that you look at one example of Pele or Dhoni, but there are several non-Peles in the field who are having problems, and if you see them very carefully, I think 1 out of 10 may probably end up needing surgery. Is that we tend to ignore it because it's a very, very benign problem according to us. But for parents, it's a nightmare when they see the child cannot play sports. So make sure that you do a proper evaluation and counsel them. Whether you want to give orthotics, whether you want to do surgery, really depends on the symptoms. Thank you very much.